These are my disclosures, and they have some bearing on this presentation, because I am also a consultant to the Smith and Nephew group, but have no direct correlation with the talk. So I think it's important to understand why is proper alignment of the knee important, because we typically know that from the pioneering work of John Insel and Chit Ranawat and the other pioneers in knee surgery, that good alignment decreases mechanical and shear stresses, particularly on the polyethylene and on the bone prosthesis interface. It helps to balance the force transmitted through the soft tissue envelope, which affects the functional outcome. And those of you who have been doing this surgery long enough will remember that when total knee replacement was first introduced by the likes of Chit Ranawat, Michael Freeman, and John Insel, we always spoke about knee replacement as being a soft tissue surgery, where bone cuts were actually a part that followed. A lot has changed since the 1980s to where we are today in the last almost 38, 40 years, and we would try and revisit this concept. So we're all experienced enough to know that poorly aligned knees will result in decreased implant survivorship, increased polywear, poor functional outcomes, and early failures leading to component loosening. So when we'll talk about alignment, what is the real issue? Despite several improvements in knee designs and surgical precisions, the functional outcomes, particularly of the mechanically aligned knee, which is really the sort of the gold standard of knee replacements, these have plateaued. A lot of articles have been written about the unsatisfied patient, and some reports, particularly those from Phil Noble and his group, allude to the fact that almost about 20% of all patients who have undergone total knee replacements are not satisfied with the results. As an alternative to this mechanical alignment, a number of options were introduced, and the 5 common alternatives that were introduced was the anatomic, which is abbreviated as A, the adjusted mechanical, the AMA, the kinematic, the KA, the restricted kinematic, and the constitutional alignment. So going back historically, John Insel, in his first article, defined the mechanical alignment technique, the distal cut being made perpendicular to the long axis at approximately 6 degrees to the anatomical axis. The tibial resection was made at right angles to the mechanical axis of the tibia, and the femoral component was placed in 3 degrees of external rotation to balance the flexion and the extension gaps. So this was the classical mechanical axis, where you see that the distal femoral angle was about 5 to 6 degrees of valgus in relation to the anatomical axis, and the tibial cut was perpendicular to the mechanical axis of the tibia. In terms of the rotational alignment, the usual landmarks that were alluded to was the Leo-Whiteside line, the transepicondylar axis, and the posterior condylar cut. And when this was done in the way that was defined by John Insel and his group, and the mechanical axis of the tibia resection was at right angles, you had a rectangular gap that was further supported by adequate soft tissue release. And the philosophy in that terminology was that the rectangular gap was equal in flexion and extension. That gave a stable construct from 0 extension to 120 degrees of flexion. The reference points for rotational alignment of the femoral component included the Leo-Whiteside line, the transepicondylar axis, which was the axis between the medial and the lateral epicondyle, and the posterior condylar axis, which is why we externally rotated this by 3 degrees on the femoral side. On the tibial side, the resection was pretty much at dead right angles to the long axis of the mechanical axis of tibia. And when this was carried out in this fashion, you obtained a rectangular gap. You then balance the ligaments, either by releases or pie crusting, depending on what sort of deformity you were dealing with, and then tested out your range of flexion through 0, 30, 60, 75, 90, and 120. And hopefully you got a good construct, a stable knee through the entire arc of motion. The adjusted mechanical alignment technique was to undercorrect the constitutional frontal deformity, the varus valgus, to a maximum of 3 degrees. So here you start to see a variation coming up. And the constitutional deformities are preserved while severe deformities are attenuated. In terms of the implant positioning on the femoral side, all the adjustment is done on the femoral side, but the tibial component is still kept in 90 degrees, which is the mechanical alignment. Various authors have reported good functional outcomes and long-term survivorships in both varus and valgus deformed knees. 1993, Hollister introduced the concept of the true knee resurfacing, and he based this on the 3-dimensional alignment of the components and actually called it a patient-specific and a ligament-sparing surgery. And this was really the precursor, if you will, of what Stephen Howell now calls the kinematic technique. We've had a fair amount of discussion. I've had several rounds of debates in international congresses with Stephen Howell, including one at the CCJR. And one of the points that I looked at, and one of my defense points was when I presented an X-ray that looked something like this and asked him on what grounds we could correct these deformities by sparing ligament release or being patient specific, and how the 3 degrees of varus alignment that they allude to and chase is achievable in these kind of severe deformities. So in the kinematic principle, the thickness of the femoral bone resection matches accurately the thickness of the femoral component, and all the resected bone wafers are actually measured and recut for varus and valgus alignment. And in a kinematically aligned knee, the femoral cut is made in 1 to 2 degrees more valgus, and the tibial cut is made in 1 to 2 degrees of more varus as compared with the mechanical alignment. So this is really the kinematic principle based, and these are some of Stephen Howell's original diagrams. The transverse axis about which the patella flexes, the transverse axis, the green is the transverse axis about which the tibia flexes and extends. And the symmetric single radius femoral condyles is really the principle along which the kinematic principle is based. Now, when you look at the kinematic alignment versus the mechanical alignment, in the kinematic alignment, the posterior femoral cut is made parallel to the posterior condylar line, which is the dotted blue line. Whereas in the mechanically aligned knee, the femoral cut is made with 3 degrees of external rotation parallel to the tibial cut. So there is fundamentally a completely different approach between the two techniques. Now, there are several advantages of the mechanical alignment: less stress, and it has been shown that the highest stress of the tibia is in the subcondylar region. And several FEA models have shown that neutral alignment significantly decreases stress at the bone compared with the varus alignment. There is much less stress on the polyethylene liners. And let's look at it historically. These are very old articles, and some of you might actually argue that how relevant these findings are. So let's just walk down. And Matsuda in 1999, as far almost 23 years ago, alluded to the fact that varus alignment would increase the wear of polyethylene while neutral alignment was preferred. You move forward in time, 2016, and you look at the lift-off motion of the femoral component with 5 degrees of varus alignment and a combination of 2 degrees of varus and 2 millimeters of lateral laxity. In these patients who had neutral alignment, there was no lift-off and more stability. So the patients had a greater PROMS recording, and the HSS scores were much better, even when the knees had up to about 4 to 5 millimeters of laxity. In terms of further reports, 2016, postoperative function was better with the neutral alignment than with the mild valgus or varus knees. And 2013, Matsuda, yet again, he's written prolifically on this subject, various postoperative alignment negatively correlated with satisfaction. Again, in terms of implant durability and function, mechanical alignment has stood the test of time. The disadvantage of the kinematic alignment as we know it today is it restores the natural varus and creates the risk of inconsistent positions because it's very hard to actually accurately bail out the 2 to 3 degrees. And this was actually, interestingly enough, alluded to by Stephen Howell himself in the KSST article of 2013. The contact stresses on the patellofemoral joint, again, Ishikawa in 2015, are considerably increased after the kinematically aligned knees, and this might affect patient longevity. The other disadvantage is, again, coming out of Stephen Howell's reports in John Insull's book. Kinematic alignment restores the natural varus, but increases the risk of early implant failure. So when I actually questioned him on this, he said that these were early data and sort of the learning curves, and these no longer are the guidelines. So he introduced this as an honest reflection of his early findings. With the kinematic alignment, it's also necessary to avoid excessive varus tilt, because this can cause increased medial compartment wear even when the ideal alignment is achieved. And finally, we're starting to get about the 8 to 10 year follow-up data on kinematic alignment, and it has been reported to be reasonably good. But the real point is it better than what we have on the mechanical aligned knees, which give out almost 90% survivorship at between 20 to 22 years. Coming to the constitutional alignment, this is really the new buzzword. This is popularized by Johan Bellemans. This was the Chitranavath gold medal paper and is reported in 2012. He introduced the concept of constitutional alignment, but the difference he did, that he mentioned, was he introduced the varus in the articulation, not in the tibial cut. So in a way, he embraced the best of Stephen Howell's concepts and John Insull's concept. Interestingly enough, there are several authors who have expressed a cautionary note on the possibility of increased tibial component migration using RSA studies, and this is one of the very recent articles from David Parker in the JBJS American volume in 2019. So various authors have questioned the veracity of even the constitutional alignment. When you look at the literature support, again, we're going back historically. This is a very old article, almost 30 years old. Mechanical axis, when it crossed the varus alignment beyond a certain point, there was a significantly high incidence of loosening. More recent articles, patients who achieved alignment within 3 degrees had a significantly better alignment as compared with outliers. Again, 2009 articles, failure rate 0.5 neutral, 1.5 in varus, and 1.8 in varus and 1.5 in the valgus group. They concluded that the goal of TKR work should be to restore alignment within 3 to 7 degrees of valgus. More recent articles, Lombardi and his group, Keith Barron, found a substantial evidence advocating a neutral mechanical axis and up to about 5 degrees of valgus alignment, and they believe that this provided the safest margin for error. Merrill Ritter's group were very large series, significantly lower rates in neutrally aligned knees, and when the tibial component was less than 90 degrees, which meant that in varus, and the femoral component was greater than 8 degrees, the failure rate was 8.7%, as opposed to 0.8% when it was within the mechanically aligned construct range. More recent articles, we look at gait analysis, 3D gait analysis comparing kinetic variables between the MA and the K group. Really no difference between the two groups to advocate one technique over the other. When we look at more recent articles, and this is coming out of 2017 and 14, mechanical versus kinematic alignment, 4 RCTs, no differences in outcomes. Several authors have alluded to this. The new buzzword in arthroplasty is robotics, and it's certainly caught the fancy of a lot of us. Again, when we look at robotic versus conventional surgery, 3 RCTs, none reported any major differences. This is a very, very interesting article. This is a 2020 article by Matar. kinematic alignment and robotic surgery, 7-hour CTs. One of the key issues that a lot of people talk about when they do robotic surgery is you are able to titrate that 2 or 2.5 or 3 degrees of varus, which is hard to achieve when you're doing it mechanically. But this again demonstrated no differences in clinical outcomes. They concluded that newer technologies certainly must be embraced and encouraged, but with caution and done judiciously. They also encourage that finally follow the established practices and principles of total knee arthroplasty. In conclusion, I would submit that of all the articles that I reviewed and all the alignments that are currently available, mechanical access is possibly the most extensively studied and widely practiced, continues to be the gold standard. Kinematic is still under evaluation and much longer follow-ups are needed to be able to come out with the same conclusions that we already have available to us on the mechanical access front. And rather than blindly trusting one single method of alignment, I think each surgery should be titrated to the need of the patient, trying to reproduce as far as possible the preoperative anatomy of that individual. All I would really like to say is an orthopedic surgeon should be well versed with concepts of ligament balancing and measured resection to achieve the best possible results. So this is the article that I was talking about, and this is something that I would very strongly advocate every one of you to read through. This is an absolutely amazing article, 47,000 cases and several meta-analysis that was reviewed by Matar, and this article is available in JOA 2020. Standard options work well over time. Clearly, there is no best way to perform a total knee replacement, nor a way that unequivocally improves the outcome. With that, I'd like to thank you for your kind attention, and I hope I have made some sense of the alignment issues, and I'd like to thank the organizers for giving me this opportunity. Thank you very much.